Our next speaker is Dr. Devaki Nambiar, who is a health policy and systems researcher with an interest in social inclusion, health equity, gender mainstreaming and the right to health. കേരളത്തെ നന്നായി പഠിക്കാൻ ശ്രമിച്ച നന്നായി അറിയാവുന്ന ഡോക്ടർ ദേവകി നമ്പ്യാർ.
Thank you, sir. Honorable Minister, esteemed professors, mentors, gurus, on the dais in front of me, old friends and new friends, it is an honor to be here. Actually, it feels a bit like a dream, and also it feels a little bit like an exam. So I think the students in the back can relate to exam, because it is timed. So I will try to explain everything in good time, and please come and talk to me afterwards and we can discuss more. Like any good student, I have a presentation, and for the past 10 years, I have been trying to study and understand the Kerala model, like Professor Sundaraman, who has more experience. But working in a number of states across the 14 districts, particularly in the last 5 years, we have been looking at health reform, universal health coverage reform in the state, and this idea from the Sustainable Development Goals of leaving no one behind. So we were trying to assess that. How equitable is universal health coverage in the state of Kerala? Who is left behind? So let me start this story. We'll go ahead to the next slide. So many people have talked about the Ardram reforms and the social determinants of health and the reform trajectory of the state from even before. But in 2016, once the Ardram reforms were being put into place, we became interested in this transformation of primary health care in the state and how that relates to inequality. Now, Kerala as a state may have less inequality than other states of India, but there is still a commitment of the state government to address that, as even the health secretary's presentation mentioned. So we were trying to support that process, asking the question, what are the magnitudes of inequalities? Who has better outcomes than other people? And why? What are the mechanisms underlying this? Why is that happening? So with this, we started our project. If we go to the next slide, I'll tell you a little bit about our overall approach in this work. So this was a collaborative mixed methods health systems study. And the first order of business was permissions, because Kerala is already a learning state and there is a lot of expertise in health equity. So we wanted to make sure that the department was being served by our research. And so they told us, look, your big idea and your academic thing is fine, but you need to focus more specifically on Ardram reforms, and they authorized our study. And the promise was that we will carry out regular briefings and keep updating at the state level, at the district level, but also very much at the facility level, as much as possible, our progress. And I'm proud to say we have done this. And today, thanks to Dr. Jamila, I have this opportunity to share with you all as well. All this data is yours, and it will be the custodianship of the data is with the State Health Systems Resource Center, which has been a very powerful supporter, guide, and mentor for this work. We'll go to the next slide. There is way too much information on this, but this is showing you all the things we did over 5 years, from 2018 up to this year. One of our speakers, Dr. Pillai, was talking about the need to have metrics and indicators. We started with that. We wanted to understand, how do we measure health reform in Kerala? So we went through this process of deciding that across multiple levels of the health system, asking, what should we measure? And this was at the time of Ardram reforms. And then we said, well, okay, we've decided some indicators. Now, where will we get the information on them? Some of the information was not available in surveys or existing data. So you can see in 2019, we carried out data collection, and we went to 4 districts, Alappuzha, Kollam, Trivandrum, and Kasaragod. And we had a systematic research-based process to select these 4 districts. And we went to over 3,000 households across these areas and got information from more than 12,000 people, representing hopefully a good cross-section of the state. After that, of course, COVID hit. I also had a baby. And we spent some of our time focusing on secondary analyses and not trying to introduce risk as researchers going in and doing research. So in 2020, our focus was on using the data we already have and doing analysis. But then the health secretary said, look, in 2021, it's time for you to understand what is in the minds of the health system actors who have been struggling through COVID and trying to keep the care going, keep the services going. So we did that in 2021. But we were also interested in hearing from groups left behind, populations that face disadvantage, again, as Health Secretary was saying, from the coast to the hills, from remote areas to people like fisher folk, people living with disabilities, Kudumbashri members, people working in the informal sector. All these different types of groups we tried to speak to using a group format. And then finally, we were interested in sharing what we had and learning with different kinds of actors. So we did a lot of capacity strengthening and dissemination, including a book that I have that I will share with ma'am and with all of you. And I have some QR codes if you want to look at that. So lots of methods. Let's look at findings now. We'll go to the next slide. Can we go to the next slide? Okay, great. Now, some of these, we've had some questions about these. So we asked the people, okay, you have your family health center. How is it going? Now you can see that almost 90% of the people who visited the health facilities were able to get the medicines they needed. This is a huge gap in most states of India. And you can see that the supply side is actually functioning quite well. This was in 2019, right before COVID. And 4 out of 5 people who were visiting a PHC or FHC could get their tests done. That is also great. And you can see if you're able to do that, the demand then, the expectation of Keralites will be high because 4 out of 5 of them are getting their tests. And Dr. Rajgopal, you were talking about palliative care visits. 77% of the households, not the households who have palliative care patients, but of all households, were aware of the palliative care program. That is also a very powerful thing, if you think about it. And 4 out of 5 households were aware of the outreach being done by the health system to come and look at source reduction, work on infection reduction in their homes. So really that connect was there. What else? Let's keep going. Can we go ahead? Okay, it's thinking a little bit. Then we used our quantitative data and found that there were not very large inequalities. NCD burden is high, as many of our speakers have been saying. But cis women, that is women, heterosexual women, were appearing to have more coverage of testing for blood pressure and blood glucose. They were self-reporting this. Cis men were being left out in this. So perhaps there is a need to kind of focus on these populations. And actually that is something you see all over India. So you're seeing that in Kerala as well. But prevalence, who is having high blood pressure? Who is having high blood glucose? We actually found that some of our left behind populations, like caste and tribal minorities, were having this in higher numbers. That is something we need to look at as a state. Now the second poorest quintile, when you look at the issue of insurance, which Professor Sundaraman was also mentioning, actually Kerala is reaching the poorest of the poor. The poorest 20% is covered by insurance in our survey. But the next group that may face risk of catastrophic expenditure, of becoming even more poor, they were not as much covered. But the middle groups, the slightly better off people, were covered. So some of these inequalities were seen. Now, talking a little bit about expenditure, we found that men tended to prefer the private sector, and women tended to prefer the public sector. And what ended up happening is that men, for outpatient care, just for ailments, you know, like I have a fever, I'm feeling sick, that kind of thing, they were spending 20 times more than women for their care because they were going to private sector. But even women going to the private sector were spending 1/20th of what men were spending. And then also much more in the public sector than in the public sector. And we know this, the private sector, of course, is much more expensive than the public sector. But women, we found, were also spending more because they were going more to the public sector. They were spending more than men. But here, we have an excluded group. In our entire sample of 12,000 people, we had data on only 8 trans individuals, transgender individuals. So that is actually a gap in our research. And where you see this magnifying glass, there is a need to do more research in this state using the mechanisms that Professor Reddy was talking about, the support for research. Let's look at some more findings really quick, and then I'll wrap up. So in terms of who was left behind, when we asked health system actors, there are groups like transgender groups and other groups, who do you think is getting left behind in Kerala? They said, well, you know the groups that are getting left behind. Scheduled caste, scheduled tribes, farmers, fisher folk, they are getting left behind. So there was this idea that we already have schemes, and the schemes are already designed for people who are left behind. But when COVID came about, this recognition shifted a little bit, because suddenly now, almost everyone was vulnerable to COVID, right? Don't we all have a COVID story? And there were two things I want to say about this. One is, it's a bit ironic, but this perception that we all are vulnerable can shift attention away from the most marginalized, right? Because you're trying to focus on everybody now. I don't think Kerala is on that path, because Kerala colleagues in the health system were saying, well, the vulnerability and the situation of being left behind can change during pandemics, during emergencies. And that is a very important learning and way of looking at vulnerability that we have in Kerala. We don't just decide that only these groups are vulnerable, always they will be vulnerable, we don't have to worry about anybody else. There needs to be a fluid idea of vulnerability over time and based on context. So that's what we found there. Now let's talk a little bit about, keep going. And sorry, I'm not going to read these quotes, but if you see my QR codes, you can look at all of this information. So we asked both people in the health system and people in communities what was going well with Ardram reforms. And if this comes up, yes. A lot of what they were saying was very similar. So health system actors said, look, there were new clinics, there were facilities, and people were more aware. The community said, look, there were more working hours, and there were more facilities for us. Treatment access and quality was improving from the perspective of the communities. Both health system actors and the communities were appreciating that, oh, we have medicine. We have medicine even during COVID. Extra effort was made on the supply side by the government to make sure we had continuity of care. There was a broader perception from health system actors that people trust us now. People trust us more than they have before. And even in communities, community members were saying, from disadvantaged groups, they were saying that, well, actually it feels like the attitude of providers towards us has improved. So we are happier. So that was a very reassuring finding that we saw. We also saw the critical role of local self-government institutions. That is a story for the ages of Kerala, and that was appreciated by health system actors. And the role that LSGs played in improving information and health literacy was appreciated by communities. Now you've seen all the green. Let's look at a little bit of the red on barriers. We'll go to the next slide. Okay. What made care seeking difficult? Now, in some cases, FHCs were decided by local leaders, but they were located very far away. So both from the provider side, but also for communities, getting to the actual facility was a challenge. And Dr. Rajgopal was also talking about this. How do you bundle up and get into an auto and go to the facility? Sometimes even there is a bus service, but that last mile, you have a mobility issue, you cannot get there. And that is a challenge for many communities. There are still problems of functioning in terms of fund release, the health officials and health providers being there, the timings actually being full service from the community perspective. So those gaps are still there. They need to be worked on in the state. A lot of the staff are focused on curative care, on medication. That's great, but we also need to focus on upstream determinants. We also need to focus on health promotion and prevention. And I think what I was saying earlier, there are a lot of demands because there is a base level of satisfaction in Kerala with the public sector. But if there is overcrowding, if there is waiting, people don't have the time. They have to go to the private sector. And this is a challenge of Kerala being a victim of your own success. People come to the public sector, but then there are too many people in the public sector. And then because of quality, they are leaving. And so things like facility and IT gaps seen by health providers, things like, I need this test but it's not available, those kinds of challenges were driving people away. There are still, as we have raised, and Health Secretary Sir also mentioned this, with e-health we have a way to go to really make that function and activate for the supply side. And even on the community side, the feeling was like, can we use technology a little bit more? Can our health workers get more training on how to use WhatsApp to combat disinformation and also give out correct information about our health? We'll go to the next slide now. Recommendations. I have 2 more slides on this and then I'll wrap up. So health system actors said, look, we really need to expand. And by the way, this was in 2022, and these reforms, ma'am, are actually already underway, so we're on track. Field infrastructure should be improved, greater population should be covered, and now that people are coming to facilities, we need better service coverage, whether by insurance or whether at the primary care level in terms of the services that are offered. Let's make sure that people come to these facilities for everything. What did communities say? Let's move to the next slide. They also wanted better infrastructure and enhanced facilities. More services should be covered, but also help us get to the care or bring the care to us. And one big thing that happened in Kerala during COVID is that medicines were coming to the house. With the palliative care program, services are coming to the home. So why shouldn't Keralites expect that for everyone all the time? That's a huge challenge, ma'am, for you now, and big expectation from the community. Perhaps a greater emphasis on health promotion, taking that care into the communities, and taking that awareness into communities can be a way of reaching them where they are. I'll just go to the next slide. So what we've been very proud of is, and of course we are not the only ones doing this work, so we've been very grateful for the support of Professor T.S. Anish from the Government Medical College, Malappuram, and Professor Rakhal Gaitonde from Sri Chitra Institute. And we've been putting together evidence from across the state, all the academics in the state who are interested in health equity. And I'm proud to say we have a special issue in a global international journal called the International Journal for Equity in Health. 4 academic papers are already published. And for the first time ever, they will soon be publishing the abstracts in Malayalam. And this is a first time for any BMC journal ever, so we're very proud of that. In addition to that, featuring 2 of these films are about our research, but we've also made documentary films in partnership with other eminent scholars and research institutions like the State Health Systems Resource Center, ably led by Dr. Jitesh, and other eminent institutions on different health equity issues. So you should definitely check these out. These are on YouTube, just to explore this issue of health equity that a lot of people seem to care about in the state. We'll go to our next slide, which I think is about limitations. So I can't be a researcher and not talk about what we didn't do. We also left groups behind. So for example, we were not able to in great depth look at certain groups who are vulnerable. So this is an ongoing project for researchers and also for the government and for the civil society, LSGs, everybody. It's a shared project of making sure we are finding those people and supporting them and hearing them. We have some dissemination booklets, and I'm sorry, I'm technically a Malayali, but my Malayalam is terrible. So this is our first opportunity to disseminate to Malayalis in general. So I hope Dr. Jitesh is able to get into some of this, and you'll ask questions and look at our information. But we want to be able to have more conversations about this research, about what's happening with health equity in Kerala. The good thing is that there is a basic framework for PHC reform in the state. The whole world is looking at this right now with respect to sustainable development goals. Kerala is an early adopter. It already has a model. There is so much for the country and the world to learn from the state. And finally, the way that the government has functioned, trying to work, and it's very difficult, but trying always to work with local self-government leaders, with technocrats, doing their best there, and also with civil society, academics and so on. That kind of whole of society approach is commendable, it can be strengthened, and it should continue. We'll go to the next slide, and I think I have a last bit of information. I'd like to acknowledge in particular Dr. Hari Shankar and Jason Joseph. There are other members of our team, but they have been up till actually even yesterday going to all our facilities and districts and disseminating and making sure that research reaches the hands of people who have the power to make decisions and to govern their own health. So we're quite proud of that. We hope to continue that. And of course, this research wouldn't be possible with a very, very large group of people. Many of you are here. And my next slide, I think, acknowledges all of them. That's a lot of names. And it's even going off the slide, so sorry about that. This is your project, and we're very grateful for all the help you've done. I'll end with the last slide that has some QR codes. Maybe as I go back, you all can try to see if you can find them. We have the videos, the fact sheets, and the research articles that we've done on this work. Thank you for the great inspiration that you all are for us researchers and the lessons that we all continue to learn together.